Good afternoon to all my respected teachers and my friends. I am Monisha Chatterjee and today my topic of presentation is CSF Circulation and Hydrocephalus. CSF, the cerebrospinal fluid, is present on the ventricles of the brain, the cisterns surrounding the brain, and the subarachnoid space of the brain and the spinal cord. Its volume is 50 milliliter in infants and 150 milliliter in adults. The main function of CSF is protection. When the head receives a blow, the arachnoid slides over the dura and the brain tends to move. But this motion is inhibited by the CSF cushion. Also, CSF acts as a buffer, as a medium for the exchange of nutrients, the harmful toxic metabolites, and also for exchange of the regulatory factors. The CSF is mostly formed on the choroid plexuses of all the four ventricles, mainly the two lateral ventricles, a smaller amount from the ependymal surfaces of the ventricles and arachnoidal membranes, a very little amount from the perivascular spaces of the blood vessels that come from the brain. Now, for the CSF formation, in the epithelial cells that lie surrounding the choroid plexuses, the active transport of sodium ion occurs, and in order to maintain the charge balance, the chloride ions are also transported inside the choroid plexus, and immediately the osmosis of water occurs through the aquaporins and the CSF is formed. Also, small amount of glucose enters into the CSF and the potassium and bicarbonate ions are excreted out of the CSF into the capillary vessels that are present outside the choroid plexus. Now, for the CSF circulation, it occurs by the virtue of the pressure gradient that extends between the ventricles and the venous sinuses. First, after formation of CSF over the lateral ventricles, it comes to the third ventricle through the foramen of Monro. Then it comes to the narrow cerebral aqueduct to enter the fourth ventricle. From the fourth ventricle, it exits through two lateral foramen of Lusca and one medial foramen of Magendie to enter the cistern magna. Cisterna magna is connected with the subarachnoid space that is shown on this light blue coloration. After moving through the subarachnoid space, it enters the arachnoid villus. These arachnoid villus are the minute finger-like projections that are entry into the superior sagittal sinuses. Now the normal intraventricular pressure is 180 mm water and the normal pressure within the superior sagittal sinus is 90 mm water. So any extra amount of fluid within this CSF of the subarachnoid space exits into the through this arachnoid villi and are absorbed into the superior sagittal and other dural venous sinuses. The rate of CSF formation is 20 milliliter per hour and 550 milliliter per day. Now we come to the topic hydrocephalus. It is a diverse group of conditions resulting from impaired circulation or absorption of CSF or rarely increased production of CSF, which leading to increased volume of CSF and ventricular enlargement. The causes of hydrocephalus in pediatric age group are divided into congenital and the acquired. Among the congenital, the causes are X-linked aqueductal stenosis, the Dandy-Walker malformation, which is the cystic dilation of the ventricles with hypoplasia of the cerebellar thymus and small posterior cranial fossa. And and Arnold-Chiari malformation. Mostly the Chiari 2 malformation is associated with hydrocephalus with meningomyelocele. Also intrauterine infection, vein of Galen malformation and genetic dysplasia are the other causes. In the acquired causes, the intraventricular hemorrhage occur in the premature infants which lead to the subarachnoid hemorrhage and leading to communicating hydrocephalus. Also meningitis, tumors and space occupying lesions mostly in the posterior cranial fossa are the other causes. Hydrocephalus is broadly divided into two groups, obstructive or non-communicating and non-obstructive or communicating. Also there is one another group which is traction of CSF due to causes papilloma which is very rare. Obstructive, the causes include aqueductal stenosis and other lesion ventricles. The causes for non-obstructive hydrocephalus include post-hemorrhage, CSF infection and raised CSF proteins which lead to impairment of absorption of CSF. Now coming to the clinical features. In infants, the accelerated enlargement of head circumference is the most prominent sign which can be evident from serial measurement of head circumference. Anterior frontal nape wide open and bulging and skull veins are dilated. As we can see in this picture, this is a photo of a patient who was admitted in our some hospital, and also broad forehead, setting sun eye sign or down gaze nystagmus. Other long tract signs include creased tendon reflexes, spasticity, clonus, Babinski sign, irritability, headache, lethargy, poor appetite, projectile vomiting. On percussion, McEwen or crackpot sound is heard. Also, some other signs can be elicited specific to some diseases such as transillumination test positive on Dandy-Walker malformation or audible cranial buoy on vein of Galen malformation. Coming to the diagnosis. When the frontanel is open, transcranial ultrasound can be done to assess ventricle size. CT scan and MRI provides details of severity and etiology. These are photos of a child who was admitted in some hospital who had complaints of nystagmus and about recurrent episodes of projectile vomiting, 15 episodes per day. On these T2 MRI images, we can see one cystic lesion on the lateral ventricles and third ventricle, which is an enlarged ventricles with periventricular oozing, which is suggestive of medulloblastomy. This is another MRI images of another patient who was admitted with complaints of developmental delay. He had a history of Chiari 2 malformation with meningomyelocele, neurogenic bladder and paraplegia. On this taken during his around day 15, we can see grossly enlarged ventricles with dysgenesis of corpus callosum and small posterior cranial fossa. For communicating hydrocephalus, lumbar puncture is diagnostic as well as therapeutic. For non-communicating or obstructive hydrocephalus, lumbar puncture is contraindicated. Differential diagnosis for a baby with large broad head include rickets, hemolytic anemia, osteogenesis imperfecta, achondroplasia, familial macrocephaly, megalencephaly and hydranencephaly. Coming to the treatment. Treatment depends upon the cause. Acute obstructive hydrocephalus is a medical emergency because anytime it can lead to coma and respiratory arrest. Furosemide and acetazolamide can be used to decrease the CSF production, and corticosteroids can be given for post-infective hydrocephalus, and other managements are to be done as for the raised intracranial pressure. Mostly the management for shunt is given to the patient. It consists of two catheters. One catheter is inserted to the lateral ventricle and another one is given subcutaneously on the abdomen, and these are joined by one shunt valve which acts as a reservoir for CSF and it maintains the flow of the CSF. Although there are many complications for VP shunt such as infection, shunt dislodgement or even over drainage, for which repeat surgeries are needed. Endoscopic third ventriculostomy is done mostly for the obstructive hydrocephalus due to aqueductal stenosis. Here a neuroendoscope is inserted through the lateral ventricle, which is inserted into the foramen of Monro into the third ventricle. It helps to create a space for which the free flow of CSF from the third ventricle occurs on the adjacent subarachnoid systems, and as a result the intracranial tension can be reduced. Also, there are many complications such as reblockage can occur with this surgery, but repeat surgeries is essential for the patients. The untreated hydrocephalus can lead to the rapid and accelerated enlargement of the head and lead to the thinning of the cranial fold. Once the cranial sutures have been fused, the children usually succumb due to raised intracranial tension. Thus, hydrocephalic children are prone to have developmental disabilities. Visual problems include strabismus, optic atrophy due to raised intracranial tension, visuospatial abnormalities, and reduced range of vision. Also, accelerated pubertal development can occur due to increased gonadotropin secretion because of raised intracranial tension. The incidence of hydrocephalus is more on the developing countries like India than the developed countries. The congenital hydrocephalus is 0.2 to 0.5 per thousand live births. Even after the successful treatment, the multidisciplinary approach is needed for the good follow-up for the patients. This is evident from the last picture given here, how